Hello and a very good evening and a hearty welcome to all my friends. Thank you so much for joining in on my YouTube channel. I'm Dr. Mukhmohit Singh, and today we are going to discuss about the high yield points in community medicine. I know you must be looking like such a droopy face right now that why on earth are we studying community medicine back again? And I know this AIMS notification, it has given such a big blow to many people, and it has come on a platter giving mood disorder to so many people, different mood disorders. Some people are frustrated right now. Some students are devastated by this notification. Some are like in Punjabi we say sannu ki. They were not prepared before, they are not prepared now also. And some students are in that denial phase that maybe government will again postpone the exam. So whatever it is, beta, I want you to understand that you have to fight it out. You are a warrior, you are a strong person, and together we are going to overcome this difficulty. So what I have done is I have just played my part. Whatever I knew, whatever came to my mind, I have tried to put that whole thing in this 2 hour session for community medicine. Now, in earlier before this COVID thing, I was thinking PSM is of three types. Either you are talking of medical research, epidemiology, biostats, screening, or you're talking of public health like communicable disease, national health programs, non-communicable disease, or you're talking of preventive medicine like nutrition, environment, occupational health, biomedical waste management, and so on. But now I think PSM or community medicine has three parts. One is biomedical waste management, next is COVID, and third is PSM. So in case you are a person in case you are a student who's thinking that maybe I'll start speaking about biomedical waste, then answer is no. I am not going to take biomedical waste because biomedical waste has been dealt in detail in another YouTube videos. In case you are a Marrow subscriber, you already have the whole thing in your Marrow video app. But in case you are not Marrow subscriber, then we already have biomedical waste management videos available on my YouTube channel. In case you are a student who's looking for updates in community medicine, you have already learned about PSM. Now you're looking for updates. Beta, for updates, I have another video which was launched in April 2021. So you just go and have a look at this video in April 2021. I made this video. It has all the updates till 2021. You talk about TB updates, NPCB updates, Kayakalp updates, data in community medicine, rabies in brief, evergreen doubts. I have done almost everything. The link will be shared to you in the description box. So biomedical waste I'm not doing. Updates in community medicine I'm not doing. COVID, I have a separate playlist on COVID on my YouTube channel. You can watch that. So what I'm going to do right now in these 2 hours, I'm going to try to complete almost all the PSM which is apart from these things. We are going to talk about most of the important basic things that you need to remember for your exam. Right? So let's get started and take it on. First topic is we are going to talk about the yelly topic, the most yucky topic which you don't at all like, that is the medical research. Medical research, epidemiology. Epidemiology is primarily having 4 study designs. We will have analytical studies, descriptive studies, experimental studies, or evidence-based medicine. The descriptive and the analytical, they both come under the observational study designs. Observational studies, then we have the experimental and the evidence. So technically we have 3 groups: observational studies, experimental studies, and evidence. Observation can further be divided into descriptive studies or analytical studies. What are these descriptive study designs or analytical study designs? If you talk about the descriptive study design, that is on the top, I am going to talk. Descriptive study designs where you are going to describe the person. For example, describing the person means you have a patient and you look at that patient, that what is happening. Is there a fungal disease? Is there a parasitic disease? Is there a viral disease? And what were the signs and symptoms? What is happening to one case? That is a case study, or you take many cases like this, that is known as case series. So these type of study designs are the most basic study designs called as descriptive studies. Next, we come over to analytical studies. Analytical studies can further be classified into cross-section studies, case control studies, or cohort studies. Cross-section studies, you take a population. No studies gives us prevalence except the cross-section study. Cross-section study gives you nothing except the prevalence. I think I have laid a lot of stress on this point. Prevalence studies are the cross section studies. रट लो इसको, याद कर लो. Next is cross section studies जो होती हैं, they are the snapshot of the population. Like you just take the whole population and you just do a survey on them. So you'll find out how many people are diseased or non-diseased, that is prevalence, and you take the snapshot of the population. Next in line is another study that is called as case control study. In this you take cases and you take controls. अब ध्यान से try to understand it very carefully. You take cases and you take controls. So you take cases, that means they already have the disease, and you take controls, that means you are sure that they don't have the disease. So technically you are taking diseased people and non-diseased people, and you go and ask them that did you have that risk factor, yes or no. So that means before doing a case control study, you should technically have formulated that maybe these are the risk factors. So finding the risk factors is done by cross-section study, and then once you think that these are the risk factors, then you do a case control study in which you go and ask them. The points for you to remember for your exam: in case control study, you always take disease and non-disease, or cases and control, and you ask them. So you are going forward in time or you are going backward in time. हम वो diseased को लेके पूछते हैं, we ask them that do you have that risk factor, right? So once you go and ask them that do you have that risk factor, that phenomena is called as retrospective study design. You are going back in time. So time में पीछे जा रहे हो आप, समय में पीछे जा रहे हो, going back in time, retrospective study designs. And in these study designs you go from disease to risk factor or risk factor to disease. We go from disease, we take the disease and we go towards the risk factor. इसको कहते हैं we go from effect to cause, because disease effect हुआ ना. So you start from effect and you go towards the cause, and it is done for rare diseases. Case control study is done for rare diseases, and please remember, case control study में you calculate odds ratio. Prevalence is calculated in cross-section study. Odds ratio is calculated in case control study. Case control study, points to remember, very quick, just finish it off. It is done for rare diseases. It goes from disease to the risk factor, from effect to cause. It is retrospective study design. It gives you odds ratio. बस ये चार बातें. There is a special bias which is there in case control study. That particular bias is called as a recall bias. That bias is called as a recall bias. That's a specific bias that we have in medical research. Next is, what are cohort studies? So in cohort studies, you take a group of population. Mind the words. See the words that I'm saying. You take a group of population, and all that population should not be having the disease. So we take a group of population, they are not having disease. However, some are having risk factor and some are no risk factor. So some will have risk factor, some are without risk factor, and then you follow them. Mark the words, you follow them. You follow them for over some time, and then you find out whether they develop the disease or they don't develop the disease. So technically, in the previous study, पिछली study में क्या बात किया था case control में? You took disease and non-disease. In cohort, what do you take? You take people without the disease and you follow them whether they develop disease, yes or no. This follow-up study is also called as a cohort study. It is a longitudinal study, and it goes from effect to cause या cause to effect. क्या कहोगे? Disease, you take up the disease and then you ask for risk factors, or you take the risk factor people and then follow them up for disease. You follow them up. So it is from cause to effect. So you start with the cause, that is the risk factor, and then you move towards the effect. So this type of study is a prospective study design. It is a follow-up study. It is a prospective study design. Please remember that in cohort studies, you will calculate risk ratios. You will calculate relative risk. अब वो क्या होते हैं? What is odds ratio? What is relative risk? We'll discuss it right away. But please remember, cross-section study will give you, please speak with me, cross-section studies will give you prevalence, case control studies will give you odds ratio, cohort studies will give you risk ratios or relative risk. Now, please remember, what are these cohort studies and what are these relative risk, and what do we mean by this? Odds ratio is calculated in case control study. It is given by the formula AD over BC. What is this AD over BC? So let us say that this is a group of population. In this you have people who are diseased and people who are healthy. So that means these are my cases and these are my controls. right? In this, I find out how many people are with the risk factor positive, or there is no risk factor negative. So let me just put these cells as A, B, C, and D. So what I do is I do this mathematics that A and D, that is the opposite diagonal things, divided by B and C, that is this. So you do AD divided by BC. This ratio is called as odds ratio. It is found in case control studies. Can you remember this? Case control studies, odds ratio formula is AD by BC. एम्स का एग्जाम देने जा रहे हो, there is a chance you might get simple numericals based on how to calculate the odds ratio. You just need to calculate the odds ratio by doing the, it is also called as a cross product ratio. Why cross product? Because it is like cross product, right? Opposite sides का product ले रहे हैं ना, so A into D divided by B into C. So can you remember this? Case control studies, odds ratio is AD by BC. Next is cohort study में you will calculate the relative risk. Relative risk is given by the formula incidence in exposed divided by incidence in non-exposed. Incidence in exposed divided by incidence in non-exposed. Cohort study, this is called as relative risk or risk ratios. It is the ratio of risk in exposed divided by ratio of risk in non-exposed, that is cohort study. इसके साथ ही you should also remember another formula that is called as attributable risk. What do you mean by attributable risk? Because you are going to give AIMS exam, attributable risk, because you're going to give AIMS exam, there is a chance they might ask you to calculate some numericals. They may ask you, I'm not saying they will ask you, they may ask you to calculate some numericals. So in case they do, you should be knowing how to calculate relative risk or the risk ratios or attributable risk. Attributable risk is given by the formula incidence in exposed divided by incidence in exposed divided by minus incidence in non-exposed divided by incidence in exposed. So attributable risk is given by the formula incidence exposed minus non-exposed divided by incidence in exposed. That is given as attributable risk. Attributable risk. So for details, you need to watch the whole marrow video modules, but this is just a very quick brush up. So please remember case control, cohorts, and cross section. Many times you get questions on ecological studies. What do you mean by ecological studies? Just one point for you to remember for your exam. Ecological means that the unit of study is the population. So in cross section, in case control, in cohorts, we take individual as the unit, but in ecological study we take population as the unit. In ecological study, there is a special bias. That bias is called as ecological fallacy, where the results are not valid at individual level. There is another type of advanced observation study design, which is again an analytical study, that is called as nested case control. What do you mean by this nested case control? Nested case control is a special type of cohort study. It is done for rare or expensive investigations, and it is a type of cohort study. What are the details of nested case control? It is beyond the preview of this session, but please remember all these types are types of analytical studies and they are types under the observation study designs. So that is what we had started our story. Epidemiology, you will have observation study design. Observation study designs could be descriptive, that is case series or case studies or case reports, and then you have analytical studies like case control studies, cohort studies, cross-section studies, nested case control, or ecological study design. Let us move to the next topic, that is experimental study designs. So now if we talk about the experimental study designs, which can be broadly classified into randomized trials and non-randomized trials. Next question, you might ask me that what do you mean by randomization? Randomization, what do you mean by randomization? Randomization basically technically means to balance out. What do you balance out? We balance out the effect of the confounders. We balance out the effect of confounders or the confounding or the confounders. So why would you do that? So technically it means that the unknown factors or the confoundings are not more in one group or less in another group. They should be balanced out. How would you do that? Randomization is done on the principle that the probability of putting one subject into a group, the probability or the chance, whatever you might call it, the probability or the chance should be equal, and it should be known. It should be known, it should be same, and it should be equal. Only then the chances of getting confounding people or the confounding agents or the factors in both the groups will be same, so it won't be higher in one group or lesser in another group. Are you getting it? So chance of bias जो है वो कम हो जाता है if we do randomization. I'm not saying that non-randomization trials are not good, they should not be done. I'm not saying that. Non-randomization अपनी जगह ठीक है, randomization is slightly better because इसके अंदर the bias is less. What type of bias? The confounding is less. So what are the randomized trials? Please remember, ये नाम जरूरी हैं. You need to remember these names: clinical trials, preventive trials, risk factor trials, suggestion experiments, trial of ecological agents. These all are categorized under the randomized trials. So they technically do confirmation of the hypothesis. Non-randomization also might do confirmation of the hypothesis, but they are like natural experiments, before after trials, or non-randomized trials. These non-randomized trials, we might also have a special trial where the selection bias might be there, that is known as a quasi design. Quasi experimental design. Quasi is a Spanish word which means partial. So any type of design which is partial is called as a quasi design. So I personally feel, because of the COVID pandemic, there has been so much medical research into the science of medicine, that there could be chances of you getting a question on medical research. So that's why I'm trying to train you that you should be knowing basic things about medical research. You might get lucky that the same type of questions might fall in the exam. Next is, what do you mean by evidence based medicine? Evidence based medicine is कि बहुत सारे evidence, like we were giving zinc for COVID-19, we were giving hydroxychloroquine for COVID-19, we were, whether COVID-19 spreads through aerosol, it spreads through droplets, it spreads through stool, it spreads through feces, we don't know that. So many studies were conducted, and once we do all the studies, and then you mind the words, and then you study the studies. What did I say? You study the studies. A lot of research has been conducted. One study was in Italy, another was in China, another was done in Korea, another was done in India, next one was done in US, in Germany. So many different places studies were done on COVID-19. And then you take all the studies, you put them on a table, and then you try to analyze that what is the final outcome. That understanding of final understanding of the final outcome, that is called as evidence-based medicine. Evidence-based medicine can be of two types. You can have systematic reviews, or you can have meta-analysis. Which one is the better one? The better one, or the best one, is meta-analysis. Why? Because it uses stats. So what is meta-analysis? It is a statistical approach to evidence-based medicine, and gives you the best evidence, or the topmost evidence in hierarchy. Answer is meta-analysis. So you should be knowing this, you should be remembering this. If you talk about the hierarchy of causation, this is a hierarchy of causation. You can see iske andar sabse upar, the top thing is what you have is this one, that is the meta-analysis. That's that stays on the top. So meta-analysis, practice guidelines, these are the first level of evidence. Then you have the experimental designs, then you have the cohort studies, case control studies, case reports, and then you have the editorials. I know that you already know this hierarchy, but I want to tell you something else. I want to tell you what do you mean by the level of evidence. So the first level, level 1, that is known as level 1 evidence, is usually almost always given by meta-analysis. So don't mark my words as that this is what sir has said means stone. No. Level 1 evidence is the highest level. Usually, I'm saying the word usually, if you do not have meta-analysis in place, then you take randomized control trials to be the level 1 evidence. So it all depends how much the medical research has evolved in that particular subject. If you have a lot of meta-analysis, they become the level 1 evidence. If there are no meta-analysis till date, like for a new disease like COVID-19, then you take the randomized control trials as level 1 evidence. If they are not available, cohort studies will become the level 1 evidence. Are you understanding this fact? So in case your medical research has evolved so much, then in your exam, for your exam, let's take it out. For your exam beta, you need to remember meta-analysis is level 1 evidence. But don't show me other studies, ke sir, you told wrong thing, sir, in this is written. I just want to clarify that there could be considerable overlaps depending on what level or how much evolution of medical research has taken place in a particular point or a subject or a topic. So for your MCQ exams, for your AIMS exam, NEET PG exam, meta-analysis, systematic reviews, they form the level 1 evidence. Level 2 evidence is usually by the randomized control trials. They are randomized trials and they are control trials. Then you have level 2A and 2B. 2A is randomized bigger trials and 2B is quasi randomized trials, something like this. Then you have level 3 where you can have case control studies or case disease and non-disease studies. Level 4 is usually a case report. Level 3 is case control studies. Level 2 could be cohort studies, it could be randomized clinical trials. Level 4 is usually case report or case series. Level 5 is expert opinions or editorials and things like this. So that's what is the hierarchy of evidence, and that is what you need to remember for your exam. So you have also category, apart from the level quality, apart from the level of evidence, you also have the category grade of the quality of evidence. So usually we say category A is good evidence, category B is moderate evidence, and category C is poor evidence. So these are the three grades of category of strength of recommendation, category A, B, and C. So you might have a level of evidence as 1A, 1B, 2C, 2A, and different things like this. So depending on the sample size, depending on how robust the studies are, you have different levels of evidence. So you should be knowing about this. Next is a couple of points about clinical trials. Clinical trials, we have human trials and animal trials. Animal trials are also called as preclinical trials. So clinical trials start from human trials. Clinical trials do not start from animal trials. Animal trials are preclinical trials, and उसके बाद होता है human trial. Human trials can further be classified into phase 1, 2, 3, 4. When does the FDA approval happen? When do you have the regulation of a drug, of a vaccine? The regulation of the drug or the vaccine usually happens with phase 3. So once the phase 3 is started, that means that bigger number of population is taken. Don't worry about these numbers, don't go with these numbers. This number, like for COVID-19, phase 3 started with thousands and lakhs of population because of the urgency of the vaccination system. So don't go with these numbers don't mean actually anything. But phase 1 is usually less than 100, usually less than 80 participants. Phase 2 is a few hundred, it could be 100, 200, 300, 500, 700. Phase 3 could be thousands, could be lakhs. And then you have a FDA approval. FDA approval is basically after the safety is there. And phase 4 is post marketing. After FDA approval, the companies are allowed to do marketing of the drug or marketing of the vaccine, and then they are basically allowed to promote their intervention, their drug or the vaccine. And then you do follow-up studies, and then you do post-marketing surveillance, and that is what is phase 4. So currently for COVID-19 pandemic vaccines, most of the vaccine, not most, in fact all of the vaccines are currently in phase 3. They are not given FDA approval that they can do marketing, but yes, they have been given emergency use authorization for all the drugs. So that was a brief about the epidemiology, the case studies, the case reports, the cohort, the cross section. A little bit about biostats now. You all know that there is mean, median, and mode. What is mean? Mean is the average. Median is the center point after arranging the data in ascending or descending order. And what do you mean by mode? Mode is the most frequently occurring number. So there are three things: mean, median, and mode. So in cases of skew, that is a very common question. In cases of skew means that there is not a normal distribution, that there might be some outliers. Whether the mean is bigger or the mode, very frequently you get this question. So what I have done is I do them in grammatical manner. I take a dictionary. So once I take a dictionary, what is the first word I will get? First word, kaun sa hoga? That is mean. So I'll get the mean, then median, then mode. है ना? If you open a dictionary, first word is mean, MEAN, then MEDIAN, and then you get mode. So you put them alphabetically, and in case the MCQ is asking you about the left skew, they all will start looking towards the left, And if it is a right skew, they look towards the right. What do I mean by this? If they look towards the left, that is a left skew. And if they look towards the right, that is a right skew. What do we mean by this? That means the greater or the lesser sign. So in the left skew, they'll all look, the pointy thing is towards the left. If it's a right skew, the pointy thing is towards the right. Just remember this, and that is what you need to remember. Right skew may, what is highest? The mean is highest. Highest means the biggest number, right? The mean is the biggest number, so mean is the maximum. In a left skew, what is maximum? The mode is maximum. Yes, the mode is maximum in a left skew. Are we getting it? So that's how you solve the questions on skew. Next is some of the pearls from my side for biostats, because biostats could be there in your exam. So what are the things you need to remember for biostats? What do you mean by standard error of mean? Standard error of mean is given by the formula SD over square root n. SD over square root n. Standard error of proportion, that is given by the formula PQ over n whole under root. What does P stand for? P stands for the prevalence, Q stands for 100 minus prevalence, and n stands for the sample size. Sample size. So just remember this formula for your exam. Ho sakta hai, there might be chance that you might get a direct question on this. So you should be remembering this formula. Standard of mean is given by the formula SD over square root n. Standard of proportion PQ over n. So in case you're getting proportions, percentage in your exam, use SCP. If you're getting the average or the mean in your exam, calculate the standard of mean. They will ask you to calculate it. Direct question hoga. This is an old previously asked question, coefficient of variation. They had given two population mein they asked you, they had given the mean and they had given you the sample size and the standard deviation, and they asked you that which population has more variation. So once the question asks you that which population has more variation, you need to calculate the coefficient of variation for A and coefficient of variation for B. So this is a previously, all the points, so all the pearls in fact are previously asked MCQs. So in AIMS exam, coefficient of variation is given by the formula, it is sample size, that is the standard deviation divided by mean into 100. So that is what is coefficient of variation, SD by mean into 100. So you calculate SD by mean into 100 for A population, SD by mean into 100 for B population, and then you find out which population has more variation. That is called as coefficient of variation. Next is the Z-score or the Z-score. How would you calculate the Z-score? Z-score is given by the formula observed value minus the expected value over the standard deviation. It's a simple formula. It's a direct formula. Exam mein ho sakta hai, they might ask you. Next is odds ratio and confidence interval. This is a big headache for me because I have explained it almost in every video, and again students ask me the same question almost in every platform. Telegram, social media, Facebook, Instagram, everywhere you are asking me, sir, why odds ratio confidence interval is different. So what I mean to say is that, let us say population A has a odds ratio of let us say 2.1 with the confidence interval of 0.9 to 3.8, and population B has a odds ratio of 1.6 with the ranging from 1.1 to 2.9. So which population has a significant odds ratio? That is what the question is. Which has more significant odds ratio? Please note that if the value 1, I'm repeating it again, if the value 1 lies between the confidence interval, number 1, so 0.9 on the number line, right? So 0.9 and then you have 1 and then you have 1.1, 1.2, 2.2, 3.8. So 0.9 to 3.8, where is the value 1? It lies somewhere in between na. So this odds ratio becomes a redundant odds ratio. It becomes a non-significant odds ratio. Why? Because sometimes odds ratio is less than 1, that is a protective effect, and sometimes it is 1, that is no effect, and sometimes it is more than 1, that is a positive effect. So therefore this odds ratio is non-significant, whereas this odds ratio, it is starting from 1.1, 1.2, 1.3 till 2.9. So where is number 1? Number 1 is outside this whole range, right? So if it is outside this whole range, beta, that is called as a significant odds ratio. It is called as a significant odds ratio. Just remember the value 1 on a number line. Simple here. Why do you get confused all the time? So it is odds ratio and confidence interval. Next is zone of normalcy and p-values. Very frequently you get question on this also. So please remember that within -1 to +1 standard deviation, you have 68% of the values which are lying. -2 till +2, you have 95% of the values lying, and -3 till +3, you have 99% of the values lying. So just remember this whole thing, that within -1 +1 standard deviation, 68, 95, -2 +2, and 99 for -3 and +3 standard deviation. So these are your values. This is the zone of normalcy lies. Usually we take the normal zone as between -2 and +2 standard deviation. So anything which is lying within -2 and +2 standard deviation, that is a normal. And p-value less than 0.05 is known as abnormal p-value, or this p-value is known as a significant. It is known as a significant p-value. It is called as a significant p-values. Why? Because p-value less than 0.05 will lie outside the zone of normalcy. Just remember this. Next is couple of questions coming on scatter plot. So scatter plot or correlations, let us call these scatter plots as A, B, C, D and E. Easy हो जाएगा ना मेरे लिए आपसे discuss करना. So if you look at the values in scatter plot A, the values are like left and right, here and there, they are everywhere. Whereas in category B, in scatter plot B, they are more condensed. That means, mark the words, that means the dispersion is more, dispersion is higher in scatter plot A, whereas there is less dispersion or less variation in scatter plot B. This scatter plot B and A has also a difference, that because they are more varying, the correlation might be there in A, but it is more stronger in B. This effect of correlation is measured by value R. R is given as coefficient of correlation. Coefficient of correlation, this R ranges from -1 to +1. If the R value is less than 0, if R is equal to 0, that means no correlation. Okay, if R is equal to 0, that means no correlation. But if R value is less than 0, that means it is in minus 0.8, 0.9, minus. If the value is minus, it is negative. That means it is a negative correlation. Whereas if the value of R is more than 0, that means it is in plus. It is a positive correlation. So mark this words, if the odds ratio is 1, odds ratio is +1, it means a positive association. But if the odds ratio is less than 1, that means a negative association. But if correlation coefficient, that is R, is more than 1 or more than 0, that 0.8, 0.9, it is a positive correlation. So don't get confused between value of odds ratio and value of correlation coefficient. Correlation coefficient will range from -1 to +1, that is R, -1 to +1. Odds ratio could be any number. Odds ratio, if it is equal to 1, that means no association. R equal to 0 means no association. Odds ratio equal to 1 means no association. Are you getting this? So don't get confused between these two things. Next, you should also know what is a positive association, positive correlation, or a negative correlation. Negative correlation means the one value will increase, another value will decrease. Whereas a positive correlation will have the vector going up. That is what is correlation. Next is couple of questions on box and whisker. See, in box and whisker plot, you might be asked this question because it has been so much in medical research. In COVID-19 pandemics, we drew almost everywhere. In every research there was a box and whisker. So box and whisker is technically quartiles. That means the whole data has been divided into 4 things: 1, 2, 3 and 4. We divided the data into 4 parts. So we had 4 tiles, or we had 4 like parts, or the quartiles. So in this you have the lower range, that is quartile 1, then you have the quartile 3, and median is the quartile 2. So the center point is quartile 2. So box and whisker will tell you about the distribution of data. It tells you about the distribution of data. But the exam people, AIMS people specifically may ask you, what is the difference between box and whisker A, B, and C? So in box and whisker B, in A, you can see that the median is at the center, right? The median is at the center, it is at the center point, and then you have 1, 2, 3, and 4, all equal parts. Whereas in the B, you can see that the median is kind of deviated towards one side. So that means that the normal distribution curve will be something like this. So this type of skew is what type of skew? It is a left skew or a right skew. Please remember, in skew we see the tail. You remember it? In skew you see the tail. So tail is towards the right, so therefore this is a right skew. So that means this is a right skew or a positive skew. This is a right skew or a positive skew if the median moves towards the left in a box and whisker. If the median moves towards the right in a box and whisker, that means that this data is something like this. So where is the tail? Where is the tail? The tail of the skew is on the left side. So this is beta what? This is a left skew. This is a left skew or a negative skew. Will you remember this? So don't get confused. This is a left skew. I'll just move myself a little bit just for you to show. This is a left skew or a negative skew. So इसको ऐसे भी देख सकते हो आप. Normal distribution. This is a normal distribution where the median is in the center. Then you have a positive skew and then you have a negative skew. That is what we did right now. So negative skew or a left skew. Next is this type of graph. You might have seen this type of graph so many times in COVID-19 specifically. We drew this graph everywhere for COVID-19 cases, for number of deaths, for fungal mucormycosis cases, for vaccination drives. This type of graph is too much in trend. So this is called as a Choropleth graph. Choropleth graph में predefined areas are given different shades, and based on shades you find that this area is probably less or this is more or whatever number. So different shading of the areas based on the quantitative numbers, you put them pictographically. That is what is called as a Choropleth graph. Next is couple of questions on screening of disease. So I think your whole Mayusi area or that whole depressive phase is almost done. Let us go to something interesting, that is screening of disease. We all know that in screening of disease you have two sides. You have the left side and the right side. One side you have the people who are diseased, and on the other side you have people who are healthy. So you have disease population and healthy population, the proportion of true positives, and on one side, of course, I think we all know should be test positive and test minus, right? So people who are true positives, that is test positive divided by disease, this is known as sensitivity. What is this known as? Sensitivity. Whereas the number of false negative divided by the total disease, number of false negative divided by total disease is false negative error rate. The total true negatives, this is very interesting, important, the true negatives, the people who are in actually healthy and the test is negative, the true negatives divided by all healthy, this is known as specificity. Very frequently asked MCQs, this is called as specificity. Whereas the proportion of people who are false positive, people who are unfortunately tested positive, but they were in fact healthy, the proportion of false positive divided by total healthy, this is known as false positive error rate. This is called as false positive error rate. And people who were true positives, people who were tested positive and they were diseased, divided by the total tested positive. So out of the total tested positive, how many are actually diseased also? This phenomena is called as positive predictive value. What is it called? Positive predictive value. No confusions between sensitivity and PPV. Sensitivity is true positive divided by disease. PPV is true positive divided by tested positive. Confuse mat hona. FPER is opposite. FPER is false positive divided by total healthy. On the other hand, if you talk about the true negatives, divided by the total tested negative. So total tested negative, these people have been declared as test negative by the test. Out of these people, how many are actually true negatives? This phenomena is called as the negative predictive value. Don't get confused between negative predictive value and specificity. Specificity is true negatives divided by healthy. True negatives divided by tested negative is negative predictive value. Confuse mat hona, please. So these are very simple things. You need to remember what is PPV, what is sensitivity, what is NPV, what is specificity, and what is false positive error rates, and what are the false negative error rates. I would also like to clarify over here that if you do the test in series, if you do the test in parallel, how I have remembered, forget this thing. If you do the test in parallel, the specificity decreases. You're not going to kill me for this, but that's my a very dumb mnemonic, that P goes for P. Test in parallel, specificity decreases. P goes for P goes down, P goes down, specificity parallel goes down. I know it's a dumb mnemonic, so but anyways, you need to take it from me, because there are only few days in your exam beta. Test in parallel, specificity decreases, it decreases. So don't think it increases. P goes for P. And of course, opposite of that, if parallel testing specificity decreases, in series testing the sensitivity will decrease, or in other words, the specificity will increase. Okay, so whatever it is, I have just remember this and then I derive the whole table, so you can also do the same. So now the next is communicable diseases, and this will be a slightly bigger topic, but I'll be just cruising through most important infections and basics of infection. What do we mean by sporadic, endemic, epidemic, and pandemic? Sporadic means scattered cases. Endemic means persistent presence of a disease. Epidemic means outbreaks, sudden increase in number of cases which is clearly in excess, or which is more than 2 standard deviations, or more than 80% of expected frequency, which is more than 80% of the expected frequency. And what do you mean by pandemic? I don't think we need to discuss this, because this has been dealt so many times and we all have seen the effect of pandemics and COVID-19 pandemic. It is clearly in excess disease which crosses all the boundaries, and it extends to more than 2 WHO regions. So any disease which extends to more than 2 WHO regions, that is declared as a pandemic. What do you mean by a case, a subclinical case, and carrier stage? Case is a person who shows sign and symptoms of a disease. Subclinical case, there is a disease pathology which starts. There is a disease pathogenesis which has already started in a person, but there are no sign and symptoms. This subclinical case may be true for communicable disease, may be true for non-communicable diseases, like you have subclinical thyroid, hypothyroidism. So you might have subclinical case where the disease process has already set in a person, and these subclinical cases may be communicable or non-communicable. Whereas in a carrier stage, if you talk about the carrier stage, that is more specifically we talk of communicable disease, where the disease pathology may have set in or may not have set in. Usually the answer would be may not set in, but the person may carry or harbor the infectious agent or the infectious disease. The person will carry the or harbor the infectious agent or the infectious disease, and that person is called as a carrier. The carrier stages can be of many types. You can have chronic carriers, healthy carriers, convalescent carriers, or incubatory carriers. What do you mean by chronic carrier? For a very long time. Convalescent carriers, what is the convalescent phase? जब patient बीमार हुआ, when the patient gets disease, the sign and symptoms, and once the sign and symptoms are over, mark the words, जब वो disease के जो acute sign and symptoms they are over and the patient is in recovery phase. So recovery phase is what is a convalescence phase. And incubatory phase, what do you mean by incubation period? The time difference between the entry of the organism and the first sign and symptom, that is incubatory period. So in incubatory period, usually you may get many diseases which people are spreading, and very big important disease is COVID-19. So apart from this list, there is also COVID-19, and very important from your MCQ point of view, you have diphtheria. So diphtheria, measles, mumps, polio, pertussis, hepatitis B virus, influenza, COVID-19, all these are incubatory carriers and they might have the chance of spreading the disease during their incubatory phase. Apart from that, in the convalescence phase, you have diphtheria back again. So diphtheria could also be convalescent, diphtheria could also be healthy. So you can see diphtheria has so many type of carrier stages. Similarly, for cholera, you can have convalescence carriers, you can have healthy carriers for cholera as well. Or you can have for typhoid also. For typhoid, you can see that you can have chronic carriers, healthy carriers, convalescent carriers. You can have so many different types of carriers. All said and done, सारे भूल जाओ, एक चीज मत भूलना, that is the healthy carriers. Healthy carriers, please remember, community medicine is DPT. Cholera, community medicine, cholera, M meningitis, diphtheria, D for diphtheria, P for poliomyelitis, and T for typhoid. Cholera medicine is DPT. I know it's a silly mnemonic, but as I already said you don't have an option. Abhi yehi important hai for 14 days. Just take it for granted and finish it off. Next is, many times students ask me what is the difference between a primary case, secondary case, index case. Index case, please remember, is the first observed case. It is the first observed case in the community. Whereas the primary case, it was the first case in community. First case in the community. Secondary cases are, of course, these subsequent cases which arise from the primary case. So, right? So the first observed case is called as the index case. Index case may be the primary case, may not be the primary case. Next is, what do you mean by attack rate and the secondary attack rate? Attack rate is usually the total number of total disease divided by the susceptible population, and usually the multiplicative factor is 100, but attack rate can also be per million population, per 1,000 population, per 10,000. But usually it is taken as 100, but it can be any number. It could be per 100, per 1,000, per million population, per 10,000 population, whatever number. Secondary attack rate. What do you mean by secondary attack rate? It is almost always expressed in percentages. Secondary attack rate, and secondary attack rate is number of the secondary cases. It is number of secondary cases. What do you mean by secondary cases? That means the total cases minus the primary case divided by the total susceptible. Susceptible means minus the total population minus the primary case. Are you getting it? So primary case has to be divided from the numerator and primary case has to be divided from the denominator also. So secondary cases, secondary attack rate is secondary cases divided by the total susceptible minus primary case, and usually the multiplicative factor is 100. Next is, what is incubation period, generation time, and serial interval? Incubation period is time difference between the entry of the organism till the first sign and symptom. Generation time gives you the entry till maximum communicable period. Serial interval, it is the difference between the primary case and the secondary case. Primary case and the secondary case, that is what is the serial interval. Talking about different modes of transmission, you can have direct modes of transmission or indirect mode of transmission. Only point for your AIMS exam right now is you should know that droplet transmission is a direct mode of transmission. Airborne is an indirect mode of transmission. हो जाएगा ये याद. COVID-19 को देखा गया है, it has both the transmission, droplet and airborne, but airborne is technically under the indirect mode of transmission, droplet is under the direct mode of transmission. Don't bang your head to the wall कि यार, why are we studying this? What is this PSM? Take it for granted right now that this is how it is. Whenever we have extra time, or if you can watch my videos, we have discussed over there what is the reason that airborne is an indirect transmission, droplet is a direct transmission. अब वो जो why वाला time है, why time is over, just remember for your exam right now. So it's like you just need to put every knowledge in your brain and just vomit it out on that exam day, right? So please remember, direct transmission could be direct contact, could be droplet transmission, could be contact with soil, inoculation, or vertical or the transplacental. Talking about these 2-3 things, what is anthropozoonosis? What is zooanthroponosis? Anthropo, that is man. Zoo means animal. So man and animal. First word is man. So whatever is the first word, That means that this disease we are talking in that thing. So if it is anthropozoonosis, so what is the first word? That is man. So it is from animal to man. If it is zooanthroponosis, what is the first word? That is animal. That means it is from man to the animal. Are you getting it? Anthropozoonosis, disease in man. Zooanthroponosis, disease in animals. From where? From humans. So what is zooanthroponosis? Man gives to the animals. What is anthropozoonosis? Animals gives to humans. Example is rabies for anthropozoonosis, cattle tuberculosis for zooanthroponosis, and trypanosoma cruzi for amphizoonosis, where humans give to man and human gives to animals and animals gives to human. So in also zoonosis, you should know what is epizootic, enzootic, epranthic. Epranthic means birds. So any disease which is epidemic in birds is called as epranthic. Ornithosis is disease of the birds. Enzootic is endemic in zoo animals. Epizootic is epidemic in zoo animals. Next is couple of questions on what are the louse-borne, tick-borne and flea-borne diseases. Very frequently we get this. So out of all these things, please remember that flea-borne diseases are important, and flea-borne diseases are plague, endemic typhus and shigellosis. If you talk about the louse-borne disease, you have a disease called as relapsing fever. Relapsing fever is of two types. You can have a louse-borne relapsing fever, or we can have a tick-borne relapsing fever. So relapsing fever can be on both the categories. You can either have a louse-borne relapsing, which is Borrelia recurrentis, or you can have a tick-borne relapsing, which is due to another types of Borrelia, not Borrelia recurrentis. In louse-borne, you should also remember epidemic typhus. Please don't get confused with endemic typhus, which is a flea-borne. Epidemic typhus is a louse-borne. Then you have trench fever, rickettsia quintana, and dermatitis by louse-borne. In tick-borne, you can remember that 3 ticks and 3 V. T3V3. So you can remember this as, I know it's a silly mnemonic from my side, T3 and V3, and then there is a B. T3 means tick typhus, tick paralysis, tularemia. Tick typhus, tick-borne relapsing fever, tick paralysis and tularemia. V3 viral fevers, viral hemorrhagic fevers and viral encephalitis, and B stands for babesiosis. These all are tick-borne diseases. Flea is important for you to remember. Plague, shigellosis, endemic typhus, not the epidemic typhus. Talking about all the rickettsial diseases, I know rickettsial disease is altogether big topic, but just one word over here. Out of all the rickettsial diseases, Q fever, Coxiella burnetii or Q fever is only rickettsial disease which does not have any arthropod vector. There is no arthropod vector involved in coccidiosis or in Q fever disease. Q fever is also special in this manner that all the rickettsial disease will have fever and rash except the Q fever. In coccidiosis or in Q fever, there might be involvement of ticks. This is the life cycle of Q fever that you're seeing, or Coxiella burnetii. But the tick does not transmit to humans. Tick is not from animals to human. Tick is only within the animals. So from animal to animal spread is by ticks for Coxiella burnetii. It can also be direct or it could be vertical transmission, but from animals to humans, humans get only by ingestion or by inhalation. Which is the most common route? We have inhalation as the most common route for Q fever. Q fever is a special type of rickettsial disease which does not present usually with rash and fever. It is one of the few diseases, one of the few rickettsial diseases which does not have rash. Coming to the next communicable disease, that is malaria. Malaria has generated a lot of controversy that what is the treatment for malaria. Malaria, we are having Plasmodium vivax. For Plasmodium vivax, the treatment is chloroquine. For Plasmodium vivax, the treatment is chloroquine plus primaquine. So we give chloroquine at the rate of 25 milligram for over 3 days, so 10, 10 and 5, and primaquine at the rate of 0.25 for 14 days. But for Plasmodium vivax, chloroquine does not act on Plasmodium falciparum, not vivax. For Plasmodium falciparum, chloroquine does not act on Plasmodium falciparum. So therefore, we need to give artesunate combination therapy. Artesunate combination therapy is of two types. You can have artesunate combination therapy ACT-SP. This ACT-SP is given as artesunate plus sulfadoxine and pyrimethamine. In all India, in the whole of country, we give ACT-SP. Only in northeastern states, we are giving ACT-AL. ACT-AL stands for artesunate combination therapy with lumefantrine. So it is RT-mether with lumefantrine, ACT-AL. ACT-SP is artesunate with sulfadoxine and pyrimethamine. So this is the treatment you have for Plasmodium falciparum, and for Vivax you have chloroquine and primaquine. Apart from ACT-SP and ACT-AL, for Plasmodium falciparum we are also giving primaquine. This is given as a 0.75 milligram per kg body weight as a single dose. Now, what the controversy arose was that do we give primaquine to pregnant females? Answer is no. So, will you give ACT-SP with primaquine? Answer is no. But do you give ACT-SP or ACT-AL in pregnancy? Answer is yes. So, ACT-AL is not given to children less than 5 kg. ACT-SP is not given to children age less than 5 months. AL less than 5 kg, SP is less than 5 months, but primaquine is not given in case of pregnant females, children age less than 1 year, and G6PD. So in case of pregnancy with malaria, in case a pregnant female gets malaria, what is the drug of choice? For the first trimester, we are not supposed to give ACT also. So for the first trimester, the drug of choice is quinine salt, and there are a couple of other drugs which you can give in case the patient is not accepting quinine. So technically, or as per the guidelines, the drug of choice is quinine for first trimester. For the second and third trimester, you're supposed to give ACT-AL or ACT-SP, but no primaquine. That's a period over there, and full stop of the management. But in case you're being asked in your MCQ exam that a patient who had severe falciparum malaria, what are you going to do in a sub-center or in a PHC? We are going to refer this patient to the CHC for further management, because in case of pregnancy and malaria, this could be a fulminant malaria. You should also know about some of the mosquitoes. Anopheles stephensi, it is found in urban areas. Anopheles culicephaciens is there in rural areas. Anopheles fluviatilis is there in foothills or in forest areas. And Sundicus or Dirus is in Andaman and Nicobar Islands in coastal areas. So just remember, the prevalence of these mosquitoes is kind of region specific. Talking about Ebola and Zika, Ebola had been a talk of the town, especially from the Democratic Republic of Congo. There were a couple of around 10 or 11 outbreaks in DRC, Democratic Republic of Congo. The incubation period of Ebola, it is 2 to 20 days. It is spread by direct contact and through fluids. It does not spread by air, water, soil or feces. It is only through direct contact or body fluids. Couple of times this question has been asked. And what is the most common cause of death in Ebola disease? It is usually renal failures, or it could be hemorrhagic like shock or septic shocks also. But the features, the Ebola disease is complicated by intense amount of nausea, vomiting and diarrhea with renal failure and hepatic failures. So but the most common cause of death could be, usually it is a renal failure. In case you're talking about Zika is a self-limiting mild disease. Zika is a self-limiting mild disease. However, if the Zika is there in pregnant females, it may be harmful to the mother or to the baby and may lead to some of the birth defects. So Zika in itself, it's a self-limiting mild disease, but in pregnant females it may be fulminant. The Zika spreads by Aedes species mosquito. So Zika can also be spread from person to person by sexual routes, and therefore condoms have a chance of preventing Zika spread by sexual mechanism. Next is couple of questions on chickenpox. Chickenpox, we all know, is herpes virus 3. The period of communicability of chickenpox ranges from 1 to 2 days before the rash till 4-5 days after the rash. The secondary attack rate of chickenpox is very high, up to 90% in unimmunized or the susceptible children. In children who are susceptible, 90% secondary attack rate, which is way high, which is whooping big amount of secondary attack rate. If you talk about the incubation period, that is usually from 1 to 3 weeks, 17 to 21 days, average incubation period 14 to 15 days. In case of chickenpox, we can give varicella immunoglobulin within 72 hours of exposure. Otherwise, there is a live vaccine available, that is OKA strain vaccine. And this vaccine, if given to children, usually it offers a lifelong immunity. Even after one attack, we also have a lifelong immunity for chickenpox. In case you're talking of measles, the period of communicability in chickenpox, it was from 2 days before rash till 4 5 days after rash. In measles, it is 4 5 days before, 4 5 days after. So measles has a special thing that in measles there is usually no subclinical cases. There is no subclinical cases. It does not mean there is no carrier stage, but there are no subclinical cases. Any person who has measles will have the potential to show measles, and it spreads measles. So measles can also spread before the rash onset. So that is what generates controversy and confusion among the students. Measles may carrier stage can happen. Specifically talking, measles can have a carrier stage in the incubatory phase. So there are a couple of books which say that measles has incubatory carrier stage, but technically measles has no subclinical phase, which is different from a carrier stage. So measles can spread 4 5 days before the rash till 4 5 days after the rash. The incubation period is 10 to 14 days. Measles, what is the most common associated feature? Associated feature is diarrhea. Most common associated feature with measles is what? Fever and rash now. Measles is fever and rash. So most common associated feature is diarrhea, but most common cause of death in measles is pneumonia. Most common complication is otitis media. Most common complication is otitis media. And of course, SSP is a subacute sclerosing panencephalitis, which is a dreaded complication. The vaccine which we give for measles is Edmonston Zagreb, which is a live vaccine, a freeze-dried live vaccine. In case of rubella is toga viridae. Rubella shows iceberg phenomena. I am tired of answering this on social media. Yes, rubella does have subclinical case. It does have some of the cases which do not present as a full-blown rubella, and it shows iceberg phenomena. Rubella shows iceberg phenomena. Rubella is more commonly found in 3 to 10-year age group children, and in developed countries it is on a slightly bigger age group or a higher age group of more than 15 years. In rubella, we give a vaccine that is RA27/3, which is again a live vaccine. And in case of rubella outbreaks, what is the priority? The priority is given to WRA females, and then we move over to children 1 to 14 years, and then to infants age less than 1 year. But usually for rubella, in case of outbreaks, it is very important to protect the mother so that the mother does not transmit the congenital rubella syndrome to the baby. Next is mumps. Mumps is myxovirus, and the period of communicability, like for measles we had learned 4 5 days before and after rash. Mumps is also same thing, 7 days before rash and 7 days after rash. In mumps we can have, of course, the main features is parotitis, but the complication is orchitis. So orchitis and pancreatitis are two important known complications of mumps, out of which if you're supposed to mark one answer, please mark orchitis without doubt. And the vaccine that we use is a Lin vaccine. Next is talking about influenza. Influenza is one of the diseases which is under the WHO's notifiable surveillance disease. It is under the notifiable disease. What are the diseases which are notifiable under WHO? Which are under international surveillance? That is CYPIP. That is cholera, yellow fever, plague, influenza, and poliomyelitis. Influenza is one of the diseases which is under the top hit list by WHO because of the potential of pandemic. And I think we all know, our generation now understands the impact a pandemic can have on the human race. So influenza, there are a couple of surveillance which are happening. That's called as a flu watch. So flu watch data has shown us in year 2020 we had a couple of viruses which were spreading around in the globe. So H1N1, H5N1, H3N2, and B viruses. Out of these, if you're going to mark one, either B virus or H5N1, these are the most circulating as per the 2020 flu watch data or the influenza surveillance by WHO, which released which was released in year 2020. So we have H5N1 and the B viruses, which are most circulating. So in influenza, HIV people may also be vaccinated, but in case the CD4 count is less than 100, then we need to stop this vaccination. The influenza vaccination is area and year specific. Every year we have to change the vaccine. Why? Because the H and the N component, they keep on changing. So the vaccine changes with the influenza virus, and probably this will be the understanding, the would be the same concept, would be the same gross concept on which the COVID viruses vaccine will also be made, because of the potential of getting new strains, and therefore the need to change the vaccines as well. So it will be the same thing. So for influenza, we have both types of vaccines. We have a live vaccine, which is a nasal. We also have a nasal vaccine, and we also have a killed vaccine, that is the flu shot vaccine. Talking about diphtheria, couple of times questions have been asked. There are 4 strains: gravis, mitis, belfalanti, and intermedius, and you can have different types of diphtheria. We already talked that diphtheria has a lot of carrier stages: healthy carrier stage, convalescent carriers, incubatory carriers. The infective material for diphtheria is no secretion. The incubation period ranges from less than 7 days. The period of communicability is for 14 to 28 days from the disease onset. The age it commonly affects is 1 to 5 years, and DPT vaccine is one of the most preferred thing. The best way to prevent diphtheria in community is to vaccinate everyone. So now coming and talking about some of the gastrointestinal infections, let us talk about cholera. Cholera, we have two main types, that is O1 or O139. O1 with the biotype L-TOR, and from the serotype Ogawa is most common, which is there in India, which may cause some of the outbreaks in some places. So O1 and Ogawa are very common. Then there is something called as the force of infection. So once there is cholera outbreak in a community, if you stop the offending agent, if you stop the maybe water supply, if you decontaminate the water, but still there might be a tail of infection which keeps on hanging in that area. Why does that tail of infection happen in that area? Why? Because there are so many carrier stages, and there is an ongoing contact, there is an ongoing transmission within the contacts of cholera, which causes this force of infection or the force of the outbreak. So cholera is a very tricky outbreak to handle. It requires a lot of public health understanding to stop the spread and to handle the outbreak on a community's level. Mass chemoprophylaxis are not advised. The drug of choice is tetracycline. We have 2 vaccines, Dukoral and Sankol vaccines, oral vaccines, but not very effective. For cholera or for any gastrointestinal disease, we are supposed to know the ORS, the reduced osmolarity ORS components. Please remember sodium and glucose. These are the 2 most important ions. So the value of millimoles per liter is 75. Then in line you have is chloride. Chloride, the value is 65. Then you have potassium, that is 20, and citrate is 10. Total osmolarity is 245. So please remember 75 is for sodium glucose, chloride is 65, potassium 20, citrate 10, and then you have the total osmolarity, that is 245. For typhoid, please remember again, big amount of carrier stages are there. The drug of choice for typhoid is fluoroquinolone. For typhoid, we also have 2 types of vaccine. One is oral typhi 21A vaccine, which is only given more than 5 years. It is a live vaccine. It is a live vaccine, whereas we can have a polysaccharide vaccine which can be given after 2 years. So for typhoid, we have these 2 different types of vaccine. The drug of choice is fluoroquinolones. Talking about the tetanus. Tetanus can be a potential area in your exams. Why? Because the tetanus district categorization you should be knowing. So the neonatal tetanus, amount of neonatal tetanus per 1,000 live birth, this is taken as the marker. This is taken as the main marker. most of the country, more than 95% of the districts in our country, they are neonatal tetanus elimination zone. What do you mean by that? That the neonatal tetanus is less than 0.1 per thousand live births, less than 0.1 per thousand, 0.1 cases of neonatal tetanus per thousand live births, with 99, with more than 90% TT coverage and more than 75% attended delivery cases. So that is the main yardsticks. Very few, only few tens of districts are there which are having neonatal tetanus high risk, not because of the neonatal tetanus cases, but just because the attended deliveries and the TT coverage is not appropriate. So that is about the neonatal tetanus high risk district categorization. Based on the same principle, you can also know about the NACO district categorization. The yardstick or the marker for NACO district categorization in our country is the prevalence of HIV in the ANC female. If the prevalence of HIV in ANC female is more than 1, that is category A. If it is less than 1, it is category B, C or D. If the HIV cases in high risk group is more than 5, it is category B. If it is less than 5, it is category C or D. If there are hotspots, if there are known hotspots, that is category D. Otherwise, this is category C. So no known hotspots is category D. So most of our country is again in category D. That means a low prevalence of HIV. Low prevalence of HIV. Next is, you should also remember about the syndromic management kits. So for most of the reproductive tract infections or the urinary tract infections, we have these kits available, kit 1 to 7. So you have different colors: gray kit, green kit, white, blue, red, yellow and black. For most of the cases of any kind of urethral or anorectal or cervical discharge, we are giving kit 1, that is gray, and the drug of choice, like the drugs which are inside this kit, is single tablet azithromycin and single tablet cefixime. So it is 1 tab stat of azithro and cefixime. For any case of genital ulcers which are herpetic, we are giving tablet acyclovir. And in case of non-herpetic genital ulcers, the drug of choice is penicillin, or we can have azithromycin and doxycycline in non-penicillin, in penicillin sensitive or in penicillin allergic patients. Kit 2 is for bacterial vaginosis, that is a green colored kit which contains secnidazole and fluconazole. And kit 7 is for inguinal, kit number 7, not 6, this is kit 7, is for inguinal buboes, that is a black color kit which contains doxycycline and azithromycin. So these are your syndromic management kits. Out of these, if you're going to get a question, most probably you will either get a question on kit 1 or a kit 7. Very frequently they may ask you these questions. So after finishing now communicable disease, let us come to the next topic, a very quick brush up about the health indicators. The health indicators could be PQLI, HDI, HPI and the Guinea. PQLI stands for Physical Quality of Life Index. It takes into account 3 parameters: the basic literacy rate, infant mortality rate and life expectancy at age 1 year. Life expectancy at age 1 year, this is what is PQLI. The PQLI for our country is 65. For India, it is 65, assessed in year 2017-18. Please mark the word PQLI, life expectancy at age 1 year. How did I remember? PQLI, LI, L1. I know it must be such a silly way to remember, but that's what you have now. Next is, we are going to talk about the HDI. HDI is taking into account 3 dimensions. You have dimension, mark the words are important. You have 3 dimensions, that is a healthy life, the knowledge and the standard of living. To assess these 3 dimensions, you have some of the indicators. The indicators could be life expectancy at birth. Mark the words, at PQLI you had physical quality of life index L1, life expectancy at age 1 year, whereas in HDI it is life expectancy at birth, expected years of schooling and mean years of schooling with the GNI per capita, and based on these indicators you calculate some of the dimension indices. So you can see that in some areas, like in some of the areas in America, in Australia, in some of the parts in Western Europe, then in Japan, you have these areas with higher HDI, human development index. What about the HDI in India? The HDI in India is given by the UNDP, United Nations Development Program, and they gave a HDI index of 0.645 with a rank of 131 for our country, India. The life expectancy for India is 69.7 years, which is very close to the life expectancy what we had already targeted of getting a life expectancy of achieving a life expectancy of 70 years for our country, India. What is this Gini coefficient, Gini ratio or Gini coefficient? It tells you about the degree of inequality in distribution of the wealth among the countries. That is, some people will have all the wealth and some people will be left without wealth in that particular country, which is the Gini quality or the Gini coefficient is pretty higher. The more red color you see, the more there is inequality. So it's comparatively there in the United States, some parts in South America, then you have in Russia, in India, in some parts in Africa as well. You have good amount of Gini coefficient, which represents the degree of inequality of income in those areas. Next is coming to the healthcare system in our country. We all know that there are two types of healthcare system in our country. We have a rural healthcare system and we have an urban healthcare system. Talking about the rural healthcare system, at the lowest level we have ASHA workers, then you have sub-center, PHC, primary health center, and then you have a CHC. At a PHC level, please remember 30 to 40 villages are there. That is for 25 to 30,000 population. Sub-center is for 5,000 population, ranging from 3,500 to 5,000 population. ASHA workers is for 1,000 population. ASHA worker is not for 2,000 population, or 1,000 population does not have two ASHA workers. One ASHA worker for 1,000 population, sub-center for 5,000 population, PHC for 30,000 population, CHC for 80,000 to 100,000 population. So you can remember CHC for 1 lakh population. So 1 lakh population, you have CHC, PHC, sub-center and Anganwadi center. In terms of talking about the urban healthcare system in India, we have a UPHC, urban PHC, UCHC, urban CHC, and then you have a urban A&M center, urban ASHAs called as USHAs or community health volunteer. So the urban ASHAs or the USHAs in the rural healthcare system, one ASHA was for 1,000 population. In the urban system, one ASHA worker or one USHA worker is for 1,000 to 2,500 population. Or in other words, this is a previous year MCQ also, it is for 200 to 500 households. One A&M center, that is for every 10,000 population, sub-center was for 5,000 population, urban area A&M center is for 10,000 population, rural area PHC for 30,000 population, urban area PHC for 50,000 population, rural area CHC for 1 lakh population, urban area CHC for 2,50,000 population. Talking about the population norms, about the public health policy, the IPHS system. This is the IPHS system, Indian Public Health Standards. So for sub-centers, we need to have 3 to 4 staff. For PHC, usually we say that 13 to 14 is the basic staff, desirable staff is 18 to 21. In cases of CHC, minimum staff should be 45 to 56 depending on the load and depending on what all services are being offered in CHC, but the desirable is 50 to 52 staff. These numbers may vary. They are not discrete, they are not single number. There's of course a range, right? So now talking of all the committees in public health system, the first time 1946 Bhor committee gave us the presentation of the public health system in India. Public health system was first time established by the 1946 Bhor committee, and then we had the 1962 Mudaliar committee, which gave us the Indian Medical Services Act. So they wanted to establish the Indian medical services just based on the pattern of the IAS. That is what I think you must be hearing in news also these days. Next is Chadda committee. Chadda committee, what they did was they stopped the malaria worker from coming, and they said that the malaria is almost down. So instead of this malaria worker doing only malaria work, let them integrate everything. So they combined the malaria worker with family planning and with other national health program. And they called this malaria worker as a basic health worker, which was devised by the Chadda committee. Mukherjee committee is known to de-link malaria with family planning. So they de-linked, they said malaria should be separate, family planning should be separate. That is what was done by Mukherjee committee. Jangalwala committee gave us the non-practice allowance, and more strengthening of the infrastructure. Kartar Singh started the multi-purpose worker. That is what we are using these days also. MPWs, that is the multi-purpose worker, was started by the Kartar Singh committee. Srivastav committee is known to strengthen the whole infrastructure public health system. So one establishment was done by Bhor committee, and final strengthening of the public health system was done by Srivastav committee. Apart from that, the referral services, the referral system of our country was established by Srivastav committee. And then there was a Rome scheme, that is a reorientation of medical education, given by the Srivastav committee. Bajaj committee, it is known for managing the manpower and job descriptions for regularizing the public health system in our country. I'm sorry for my writing, but that's how it is. Please remember, these committees are super easy to remember. Bhor committee is the boring committee. They gave us the public health system. They asked the 2 months of rural practice or rural internship in during your internship, 2 months of PSM in your internship. That was given by Bhor committee. Then you have Mudaliar committee, who wanted to start the Indian medical services. Chadda committee sleeps outside in an underwear, so you can remember it as a basic health worker. Mukherjee committee, very intelligent person from West Bengal. They de-linked malaria with family planning. Jangalwala gave us a jungly rule of non-practice allowance in the government, and equal pay, like single pay, should be there for all the work. So that is what was a jungly rule. Kartar Singh is a multi-purpose worker, and they started the multi-purpose worker scheme. Srivastav is Ma Saraswati, goddess of education, the Rome scheme. Bajaj committee is for manpower, finance management, job descriptions, and strengthening of the public health system in our country. Based on the IPHS norm, we now have suggested norms for health personnel in the country. All the nurses, we want one nurse for 5,000 population. We want to have health assistant. This could be your potential MCQ. One health assistant for every 30,000 population. Pharmacist should be 1 to 10,000. Lab technician 1 to 10,000. One ASHA per 1,000 population. You already know that the health worker male and female are available at the sub centers, and one sub center is for 5,000 population. So we have a health worker male and a health worker female, that is a multipurpose worker male, multipurpose worker female, one for every 5,000 population, and 3,000 population in hilly area, tribal area, and difficult to reach areas. Last topic, or one of the important topics, is demography indicators. Couple of questions are being asked on these demography indicators. There are 4 indicators. You have a GFR, general fertility rate, TFR, total fertility rate, GRR, gross reproduction rate, NRR, net reproduction rate. So technically speaking, there are 2 types of rates. You have a fertility rate, or you can have a reproduction rate. Fertility rate mein, please remember, it is always talking of the number of children. So in fertility rates, it is the total number of children. In general fertility rate, it is total number of children a female will bear. In TFR, it is total number of children a female will bear during her reproductive years, assuming the age specific fertility rate. What is the difference between fertility and reproduction? In reproduction rates, we are taking the number of daughters as the numerator. In reproduction rate, we take the number of daughters. So what is GRR? It is the number of daughter born to a female during her reproductive years, assuming the age specific fertility rate. What is NRR? NRR stands for net reproduction rate. It is the best measure. It is the most sensitive measure. It is the most sensitive measure for understanding the fertility indicators in our country. It is the number of daughters born to a couple, to a reproductive age group female, assuming the age specific fertility rates and age specific death rates. So it is one of the most sensitive indicators. So in your exam, if you get a question, if the question is saying number of children, answer is either a GFR, general fertility rate, or it is a total fertility rate. If the question is very general, number of children, a female will bear during her reproductive years? Answer is a GFR, it is a general rate. If the question is saying the same thing, number of children a female will bear during her reproductive years, assuming the age specific fertility rates, now this is called as a total fertility rate. Can you remember this? इतना याद हो जाएगा आपसे. What is the difference between GFR and TFR? TFR includes the age specific fertility rate. Otherwise, it is the same GFR. Next is what is the other side of the story. That is, we are going to talk about the GRR and NRR. If the question is saying number of daughters, now if the question is saying number of daughters born to a female during her reproductive years, assuming the age specific fertility rate. So what is the difference over here between TFR and this one is that you have replaced children with daughters. That's all. The same thing. This becomes a gross reproduction rate. It becomes a gross reproduction rate. But now if you also add death rates to it, number of daughters a female will bear during her entire life, not the reproductive years, during her entire life. During her entire life, assuming the group specific, age group specific fertility rates and death rates. This is one of the best measure. It is called as a net reproduction rate. Can you remember what is the GFR, TFR, GRR and NRR? GFR, TFR, that is a fertility rate. GRR, NRR, that is reproduction rate. Reproduction rate will take into account the daughters. Fertility rate will take into account the number of children born. So please remember for your exam, the target that we want to achieve for NRR. The NRR that we want to achieve is 1. Why do you think we want to achieve NRR of 1? Because we want to have a replacement level. NRR 1 stands for replacement level. It means that the population will be stable. That means one daughter will be there for one couple. That means for one mother, father, one daughter, at least one daughter will be there. To have one daughter, how many children should a couple have? To have one daughter, how many children should a couple have? To have one daughter, you should have at least 2.1 children. So that is the target you need to remember. The target for NRR is 1. To achieve this NRR 1, the TFR should be 2.1. To achieve the TFR of 2.1, the couple protection rate should at least be 60%. Should at least be 60%. If we have a couple protection rate of 60%, that means 60% couples are contraceptized. So 40% will reproduce. Then the total children born will be 2.1. That means the total daughters born will be 1. So to achieve NRR 1, TFR should be 2.1. To achieve TFR 2.1, the couple protection rate CPR should be 60%. So that's what you need to remember for your exam form demography point of view, demography indicators. So now I know you must be looking like this. Do you look like this or do I look like this? Either of us must be looking like this, but don't get shattered, beta. We are in the last phase, last leg of this whole community medicine high yield point discussion. I know you must be having this look now. You might be looking like a ferocious, violent rat flea who's about to bite everyone. So just take care. But right now we are going to put lovely soil on top of all the knowledge that you have taken so that you may bloom in your final exam, in your AIMS exam. Couple of questions on information, education, communication or health communication. One thing you should know, what is a one-way and a two-way communication. One-way means dictator. Only I speak, you don't speak. This one-way communication is called as a didactic communication, whereas two-way communication is called as a Socratic communication. Next is what are these lists I have written. These list is what is usually most of them are group methods of discussion. Usually most of them are group methods of discussion. What is focused group discussion? I know what you all know what is focused group discussion, but point for you to remember is it is from 6 to 12 members. Less than 6 people don't speak. More than 12 people, everyone will speak. You won't get anything, a good outcome. So 6 to 12 is the ideal focus group discussion. Then you have panel discussion. 4 or 5 people on your TV screen, everybody is blabbling, they are fighting with each other. That is what is panel discussion. Symposium is a series of lecture on a particular topic by expert, that is symposia. Then is lecture, you all know. Workshops, role play, spikes. What is spikes? Spikes is a protocol to break bad news. It is to break bad news. That is what is a spike protocol. Then is demonstration, gather. What do you mean by gather? Gather is an acronym. Greet, ask, tell, help, educate and review. Gather is an acronym for interview, for good interview technique. Conference is a conference, so mostly I told you mostly are methods of group discussion or group methods. Then is mass media, folk media, interpersonal. These are different types of communication methods. Next is this non-communicable disease 2020. We had a global action plan to decrease the non-communicable disease. I might be jumping from topic to topic because these are miscellaneous topics, so just take note of these. So 10% reduction we wanted to have in alcohol and insufficient physical activity, 10% reduction, but bigger reduction, that is 30% reduction, we wanted to have for two main risk factors which are causing non-communicable disease. Technically speaking, coronary artery disease, hypertension, obesity. We wanted to have 30% reduction in tobacco use and 30% reduction in salt and sodium intake, mean population level salt and sodium intake, to prevent hypertension, obesity, and so many things. We also wanted to have a 25% reduction in premature mortality and prevalence of the BP. Hypertension should be decreased by 25%. We want to halt obesity and diabetes epidemic. At least 50% of the people should be achieving getting good amount of drug and appropriate drug, and 80% availability of essential medicines and affordable technology to combat non-communicable disease. This is the global action plan for preventing non-communicable disease on a global scale. These are the targets that we have. Next is couple of questions which I doubt you may be asked, but still you should be knowing these images at least. What is this type? This is known as a kata thermometer. Kata thermometer is used to assess the cooling power of air. Cooling power of air. That is, we use kata. Kata does not mean to bite someone. You don't need to bite someone. Just remember, a red color thermometer is a kata thermometer. Then there is a toy like this for children to play. Tan 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 tan. This type of toy is called as a psychrometer. It is called as a psychrometer. So this is a psychrometer. It is to tell the relative air humidity. It बताएगा कि पानी कितना हवा में नमी है. So it tells you about the air humidity. Air humidity. Next is this. Again, this is a toy where the tan 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 this thing will go. This is called as anemometer. It is called as anemometer. It tells you the air velocity or the movement of air. Then this type of clip. It is a forceps. You just take someone's skin and just pinch it on, and person will say ouch. So that this is this type of clip. This is a caliper. It is called as a Herpenden caliper. It is to test what? It is to test the skin fold thickness. And this on just near to me, this is what is a chloroscope or a chlorimeter. It tells you about the chlorine level. Chloroscope or the chlorimeter. Please remember, the chlorine level in the water should be at least 0.5 parts per million ppm. It should be more than 0.5 ppm. It should be more than, chlorine level should be more than 0.5 ppm in the water, in drinkable water. Next is couple of questions on chemo prophylaxis. With due thanks to the CBS publishers, I have taken this a snapshot from CBS publisher book, Community Medicine, Conceptual Review in Community Medicine or Preventive and Social Medicine, authored by me only. But we are thankful to CBS publishers for allowing me to take this snapshot. These are the list of chemo prophylaxis and the list of diseases. So for all the diseases, you can see the chemo prophylaxis. I don't need to spend time to explain everything. It's just simple disease and chemo prophylaxis. You can halt the video, pause the video, and take note of these. And now moving forward, let us talk about another very important program that is called as IDSP, Integrated Disease Surveillance Project. This program was started way back in year 2004 under the WHO grant or the World Bank grant, and it has the word surveillance into it. Surveillance of what? It is surveillance of the epidemic prone diseases, and surveillance is carried out at three levels: syndromic case surveillance, probable case surveillance, and laboratory surveillance. So the laboratory surveillance is done by laboratory people, of course, that is common sense. The probable case surveillance is done by the medical officers or the doctors or the clinicians working in the hospitals, and the syndromic surveillance is done by the healthcare workers. So the healthcare workers will do syndromic surveillance of 6 diseases. Medical officer will do for many diseases, laboratory people will do for laboratory many diseases, but healthcare worker will do it for 6 syndromes. syndrome of, this could be your MCQ, syndrome of fever, syndrome of cough, syndrome of acute flaccid paralysis, syndrome of diarrhea, jaundice, and unknown illness. So syndrome of fever will take care of any cases of fever of measles or malaria or typhoid or Japanese encephalitis, dengue. Syndrome of cough will take care of tuberculosis. Syndrome of AFP will of course take care of poliomyelitis. Syndrome of diarrhea or acute gastroenteritis will be for cholera. Syndrome of jaundice for all the liver problems like hepatitis, leptospirosis, yellow fever, dengue, and unusual illness we have seen in COVID-19 pandemics or plague outbreaks or any emerging epidemics, that will be under unusual syndromes. So these 6 syndromes can be asked to you, and this is what is IDSP. Next is couple of questions on ICD-11 classification. Earlier we had ICD-10. Now we have a revision of the ICD-10 that is called as ICD-11 classification. The ICD-11 classification, as in 10 also we had the same. It has 3 volumes, 3 different books are there, 3 different volumes of the ICD-11 classification system is there, and they are Arabic number chapters. Earlier it was Roman chapters, so now it is Arabic numbers, and it's not that Arabic in Arabic language it is like 1, 2 and 3 normal English. Earlier it was in Roman English, and now there are 4 categories with 2 subcategories. 26 chapters. Earlier it was 21 chapters, and there is separate letter Y which is reserved for residual category, and Z is category for unspecified. Just remember these 3-4 important points about ICD-11 classification. Next is couple of questions on immunization. Many times students ask me about immunization intensified mission Indradhanush 3.0. That is what is the latest 2021 update. So under this IMI 3.0, there are how many diseases? 12 vaccine prone diseases, vaccine preventable, not prone, vaccine preventable diseases are there. So if you just count all these vaccines, there will be 12 different vaccines. In these 12 different vaccines, there are 2-3 new launched vaccines. The new launched vaccines are PCV, that is pneumococcal conjugate vaccine. It has been launched in many states, but pan-India presence is still lacking in some districts. So PCV is a kind of new vaccine. Then you have Japanese encephalitis as area specific, because only in certain districts which are Japanese encephalitis endemic districts, in those areas we are giving Japanese encephalitis vaccines. And third vaccine which is newly launched is fractional IPV. Fractional IPV is intradermal vaccines which are inactivated polio vaccines. So these are couple of your updates in universal national immunization schedule or the universal immunization program. Then there is a controversy, a doubt which I want to clarify over here is regarding the TD vaccine. We all know that earlier we were giving TT vaccine, but now instead of TT vaccine we are giving TD vaccine. Why do you think we are giving TD vaccine? The small d stands for low dose diphtheria. So earlier it was TT vaccine, now we are giving TD vaccine. But in cases of trauma, so in case a person has some fall or anything, we give TT shots, tetanus toxoid shot, right? So now, till now also we are giving for trauma cases TT vaccine. TD vaccine is only for adults like 10 to 16-year children and for pregnant females. In other cases of trauma, we are still giving tetanus toxoid. That is not replaced with TD vaccine. So just take care of that. UIP, Universal Immunization Program, is separate and trauma thing is separate. Next is you should be also remembering couple of questions on this strain. Sometimes the examiner will ask you about the strains of vaccine. So just take a pause the video and have a look at the name of the vaccine and the strain. So it's easy: BCG, Danish, OPV, Sabin, IPV, Salk, and so on. Next is couple of times you might get a question on this thing, which is a freeze sensitive vaccine, which is a heat sensitive vaccine, that is regarding the cold chain. So all the vaccines, they are stored at 2 to 8 degrees Celsius. This means what? It does not mean that at the district level or at the regional level or at the central level we are storing the vaccine at 2 to 8. No, they are stored at minus temperatures. But in the peripheries where the vaccine has to be utilized, like in PHCs or in CHCs or even in sub-centers, the vaccine carriage system should average optimum temperature should be 2 to 8 degrees temperature, 2 to 8 degrees Celsius, plus 2 to plus 8, not minus 2, not minus like less than 0. Please remember, no vaccine should be frozen. Next question which comes is, which are the freeze sensitive vaccine? The vaccines which are on the right side, the most right side, these are the freeze sensitive vaccines. So the freeze sensitive vaccine you can very well see is hepatitis B. You can see is all the TD vaccines. Then you can see that it is the pentavalent, the hexavalent, and the human papillomavirus vaccine. So for your MCQ exams under the universal immunization program, the most freeze sensitive means जिसको ठंड ज़्यादा लगती है, which are scared of cold. Those vaccines are hepatitis B, DT, TD, TT vaccines. So first, if you get hepatitis B, mark this thing in your answer. Next is, which are the heat sensitive vaccine? Heat sensitive मतलब जिसको गर्मी ज़्यादा लगती है, they are scared of heat. So they get spoiled when they are at certain higher temperatures. So heat sensitive vaccine, which is the most heat sensitive vaccine, that is the varicella zoster vaccine and the oral polio vaccine. But you should also remember that reconstituted BCG. Reconstituted BCG is the most heat sensitive, followed by varicella zoster or OPV, followed by reconstituted measles. This is the cold sensitivity of the vaccines. Next is, you are going to give me this look now. I know, but just wait, this is the last thing. These are some of the numbers in PSM. I know you are tired, I am tired. So let us talk about the numbers which you need to remember for your exam. The data keeps on changing, but I will provide you the latest data which you need to remember for your exam. The crude birth rate is 20. The crude death rate is 6.2. The infant mortality rate is 32. The maternal mortality rate is 113. Just remember this. Infant mortality 32. Maternal mortality is 113. That's all that you need to remember for your exam. If you are a distinction student, you can remember all the 10 things. All the 10 things I will be putting in the description box for you to see at any time. But please remember, for your MCQ exam, if you are just struggling to stay afloat, at least remember IMR, infant mortality 32, MMR, maternal mortality ratio, that is 113, and crude birth rate and crude death rate. Also, last point is smart things in PSM. Make sure that you do all these points in PSM. This will be like doing almost touching every aspect in community medicine. I will be putting points on these for you to remember in the description box, but please remember, you need to do something left and right near these topics. So make sure these are very frequently asked high yield topics in PSM. So with that, we finished the high yield points in community medicine. Congratulations for finishing all these things. In case you have time, you are more than welcome to join me for the questions and doubt discussion right now. In case you don't, in case you're very tired now, so take care, have a good night's sleep, and thank you so much for watching this module. Now we are opening the live discussion now. Hello friends, and so I think we have now covered most of the questions which you had in your mind, and a lot of doubts were there. So I have gathered all the doubts that you wanted to ask me, and some of the doubts that I received were, one was regarding the Cochrane. So what is a Cochrane review? Cochrane review is nothing but a collection of all the studies. It is a very good level for systematic reviews. Systematic reviews. So Cochrane essentially is for systematic reviews. Cochrane ऐसा नहीं है that it is systematic review or is it meta-analysis. A lot of people are doing meta-analysis reviews in Cochrane as well. So Cochrane सिर्फ एक area है जहाँ पे all the evidence-based medicine is collected. It is a library for evidence-based medicine. So technically, if you really get a question MCQ, so answer should be systematic reviews, but in practical level we don't have Cochrane only for systematic reviews. We also do meta-analysis in Cochrane. Cochrane is basically a library for all the collection for evidence-based medicine. Next is a second question which I received was regarding the vaccination in pregnancy, COVID vaccination in pregnancy. So please remember that initially when there was emergency approved authorization given to the COVID vaccines, they were not given for the EUA, emergency use authorization was not supposed to be given for the pregnant females and for the lactating females. But lately we have seen that for pregnant and lactating females the vaccine can be given. So there is no difference between the pregnant females and the normal people, like who are non-pregnant, females or of course males. So the time difference between Covishield is same, whatever the guidelines may change. So currently it is like 12 weeks or 3 months for Covishield and 4 to 6 weeks for Covaxin. It is the same gap. Gap is same as in non-pregnant females. Third question that was regarding the case series. Third question that is regarding the case series. Very good. That's an intelligent question. I would say that in case series, would you do prospective follow-up or would you do retrospective, or there is no follow-up? So in case there is a follow-up, in case there is an element of follow-up, then this does not become a case series. Then this actually becomes a cohort study. So that's what we had done. So technically in case series, we take multiple cases. Like if I take 10 cases of COVID patients and who are post-COVID recovered, and then I see what happens to their liver and what happens to their renal these things, and we just do that same study at the same time, that would be called as case series. But if I take those same 15 people who are post-COVID and I follow them up for 5 years, that becomes my small cohort study. Are you getting it? So there's a difference between a case series and a cohort study. In cohort study, please remember for your MCQ exam, there has to be a follow-up. In case series, there is no follow-up. In case series, this is done at a single time. It is a descriptive type of study. In descriptive studies, we do time, place, and person study. When the disease happened, when the complication happened, where did it happen, in which people did it happen. So we just describe the disease in terms of time, place, person in a case series, whereas in case you have an element of follow-up, that will eventually become a cohort study. Next point, next doubt that I received was regarding the malaria treatment. Malaria treatment in pregnancy. So in pregnancy, I told you if in case the person can have a Vivax infection or the person can have a falciparum infection. In case the falciparum infection is there, we already discussed that we are supposed to give ACT-AL or ACT-SP depending on the location of the person. ACT stands for artemisinin based combination therapy. Initially I told, I think in the session, artesunate, so that was just by mistake. So please remember, ACT stands for artemisinin based combination therapy, AL or ACT-SP, depending whether it is in northeastern states or in other parts. Please remember, in pregnancy, no primaquine is to be given. No primaquine. We have already discussed this. In case your doubt was for the Vivax infection, in case it is Vivax infection, we are giving only chloroquine as the same dosage. So chloroquine on day 1, day 2, day 3 without the primaquine. That is what you need to remember. So I think these were some of the doubts which I was supposed to answer. Apart from this, I think this session was very lengthy for you, but I have tried to discuss all the points in community medicine for you. And just before I leave, I would like to tell you that thank you so much for attending this long session. I know you must be tired, but beta, I want you to train yourself that for next 14 days, you have to hit this whole thing very hard. You have to focus and you have to hit it once and you have to hit it gold. ये 14 डेज आपको मिले हैं अपने आप को प्रूव करने के लिए. योर पेरेंट्स आर वॉचिंग यू, योर रिलेटिव्स आर वॉचिंग यू, योर फ्रेंड्स आर वॉचिंग यू. ये 14 दिन आपको मिले हैं अपने आप को प्रूव करने के लिए दैट यस यू कैन डू. Try understanding. मैं ये नहीं कह रहा, I'm not saying this that the result of the exam should be good. The result of the exam, whatever it is, whatever the result is, it is always said that कोशिश करने वालों की हार नहीं होती. People who are trying will never lose. What do I mean by this? I'm not saying that if you try, you will get a seat, you will for sure shot be ranked number 1. I'm not saying this, but at least when you stand in front of a mirror, you are honest to yourself that yes, I did whatever I could in these 14 days. That's okay. Are you understanding this? I want you to realize, self-realization, that for 14 days, if you are being dishonest to yourself, then nobody can help you. You have to be honest to yourself. You have to struggle very hard, burn the midnight oil. You have to focus yourself and you have to do whatever it takes. Whatever it takes to complete the syllabus within 14 days. After that, whatever happens is God's will. Are you getting it? At least you will stand on the front of a mirror. Your parents will be proud of you that you did whatever you were supposed to do. If you don't do what you're supposed to do, then who's going to help you? So that's what I want to give you the message. You have to fight it now. It is a war zone. So take the full opportunity. 14 days you have in hand. You have to show me that you have done your bit. And once your exam is over, please stay in touch with us, and we are very happy to help you in whatever way we can. May it be your emotional, so many students get emotional disturbances, so many students get so many different types of feelings. We are always there to help you out, but you have to prove that you are doing what you're supposed to do. That's what I want you to understand. All the very best. Take care.